Hello and welcome everyone to the Vaccines and COVID-19 Teach Out hosted by the University of Michigan. Today we are going to have an informal discussion about COVID-19, about vaccination progress, and we're going to be talking with some experts here at the University of Michigan. So how it's going to work is you can write your questions in the chat function of Zoom. If you're on Facebook, you can write your questions there. If you're on another platform, we'll be trying to keep an eye out for the questions that you may have. You can also use the Q&A function in Zoom. So please start putting in your questions. If you find a question from somebody else that you think is interesting or very similar to yours, instead of rewriting the question, you can upvote it. So we look forward to hearing your questions, and we'll be trying to answer as many of them as possible. So let me start by introducing our panelists. We have Dr. Emily Martin and Dr. Arnold Monto here. Dr. Martin is an associate professor of epidemiology at the University of Michigan. We also have Dr. Arnold Monto, who is a professor of epidemiology, also at the University of Michigan, and they are experts in infectious disease epidemiology, in particular in viral respiratory disease, and they have many studies looking also at influenza vaccine effectiveness, and within the past year, they've been heavily involved in studying the new coronavirus and working with state health departments and with international organizations as well. We also have a few people who will be responding to some of the questions in the chats. Dr. Ryan Malash is also on faculty at the University of Michigan, and he studies influenza vaccine effectiveness. We have Dr. Nina Masters, who recently successfully defended her PhD, and her research has been on vaccination coverage and predictors of outbreak potential. And then we also have Peter DeYoung, who is a PhD student who studies the transmission of viral diseases in childcare settings. So you will be seeing all these names pop up in the chat and responding to you. I should also mention I'm Abram Wagner. I'm a research assistant professor in the Department of Epidemiology, and I'll be your host and moderator. And basically, I'll be taking your questions from the chats and posing them to Drs. Martin and Dr. Monto. So I think the first major question that I saw a lot of people ask about, we asked some people to submit questions ahead of time too, but maybe you can sort of update us with what's going on with coronavirus now. So take us through what the current situation of coronavirus is and what it looks like in the near future.
Yeah, I can start with that. So we are definitely seeing around the country and then here in the state of Michigan that coronavirus rates do appear to be decreasing. We're seeing decreases in hospitalizations, and some of the metrics that we monitor are improving. There's a lot of debate amongst epidemiologists about, it's probably due to a couple of different factors that we're seeing that's driving this. We do want to recognize the fact that there are people starting to become vaccinated, so that's going to help hospitalization rates. There's probably an adjustment happening after the travel. Travel patterns over the holidays have settled in. People have settled into their regular routine. So, we're probably seeing people stay put a little bit more than we were in November and December and in early January. And some of this could just be, the respiratory viruses naturally wax and wane throughout a season. So maybe we're seeing a little bit of a contribution of that too, but we're definitely seeing a clear sign that things are getting a little bit better. Now, rates are definitely still high. Risk is still higher than we'd like it to be, but on the right track for improvement.
Yeah, I wonder, Dr. Monto, if you could also just update us with vaccination development. So where are we right now? What vaccines have already received approval or emergency use authorization, and what looks to be likely on the near horizon?
Well, we have in the United States given emergency use authorization to 2 mRNA vaccines. The same platforms developed independently by two different companies, the Pfizer vaccine and the Moderna vaccine. And those are the two vaccines that are being rolled out in the United States. The one that has had more of an international impact is the Pfizer vaccine, which has been used extensively in a number of countries, including in Israel, where as a small country, they've been able to vaccinate a significant portion of individuals. Next to come up for emergency use in the United States is the Johnson & Johnson vaccine. In fact, we are going to have a review of that vaccine on Friday at the FDA's Vaccine and Related Biologics Advisory Committee. I'm going to be chairing that meeting, as I have the other meetings approving the vaccines for emergency use. When that happens, we have a two-stage affair in the United States. When that happens, after that happens, the Advisory Committee on Immunization Practices, which is housed at the CDC, will give us recommendations on how that vaccine, once approved, should be used. So that's another vaccine that's coming online here in the United States. Other vaccines have been approved internationally, the AstraZeneca vaccine in particular, and there are some other vaccines which have not been subject to the same regulatory reviews, at least in the Western world. We have Chinese vaccines, we have the Sputnik vaccine, and some of those vaccines appear to be effective. So there's a variety of vaccines available, and it's all a question of where you are in the world.
So, Dr. Monto, could you talk to us a bit about why these vaccines were able to be developed so quickly? I think some people have just some concerns about how, we barely knew the coronavirus a year ago, and now we have vaccines which are available. So how were these vaccines able to be developed so quickly?
Well, up to now, coronaviruses have been sort of a specialty area for some people, except if you were in Asia in some cities and Toronto when SARS hit, because that was a coronavirus, and that outbreak produced interest in vaccine development. And then we had a distant cousin, the MERS virus, which occurred mainly in the African, in the Asia, in the Arabian area, mainly associated with camel vectors, but with an outbreak in Korea. And the reason I bring this up is these are closely related viruses, and they spurred vaccine development. On top of that, with the vaccine being in development, not really being evaluated extensively, then we had realization that vaccines were going to be necessary, and a great push, both financially and politically in the United States for vaccine development, which basically pushed things into the fast track. So companies that would have waited for positive results were doing studies in parallel rather than in sequence. But the process has been the same as ordinarily, except people have done things which would have been risky in terms of financial outcome, because they didn't wait to see if there were positive results. And then when it came to the approval process, we went through this in the usual way at the FDA, except for we didn't want to wait 6 months or more for final data. The approvals were done after 2 months of data. Now we're accumulating even more data. So nothing is out of the ordinary in terms of the process. What's happened is that it's just been sped up. What would have taken a lot longer has been done very quickly.
Dr. Martin, could you talk a bit about these coronavirus variants that we've been hearing about? I think some people have concerns about how well will the current vaccines work against these variants? And then also, is there potential for new variants to pop up in the future? And how will vaccines work against those ones?
Absolutely. So one thing I want to start out by being clear about is that, viruses vary. Viruses generate these changes as they transmit. And the more that they transmit and move from person to person, they create these changes. And that's a normal effect of viruses. It's something we're used to seeing. Where we get concerned is when those changes start to impact the way the virus works and the way the virus interacts with the body. So those are those variants that we see on lists that, the CDC now has a list of variants of concern. The WHO has a list of variants that we watch. So the data is pretty clear that those the variants that we're watching do spread about 50% faster. And there's still a lot of investigation going on to see whether or not the disease that these variants cause is any different. Is it more severe? Is it less severe? Now, one kind of areas you mentioned that's of high concern is, when we really worry about a variant is when the vaccine does not protect against the variant. So what that means is that the antibodies that your body produces once you've been vaccinated, can they still recognize this new strain? So far, the data looks good. This isn't like we hear, we're used to this happening with the flu vaccine, that some years there's not a good match between the flu vaccine and the strain that's circulating. So far, we have still a pretty good match between the vaccine and the variants, close enough that your antibodies from the vaccine will still provide a pretty high level of protection against the variant. It may not be quite as high as the earlier strains, but it's still high enough to really slow down the epidemic, protect against severe disease, all those things that we're primarily concerned with.
Some of the audience members have this question about, how long will COVID-19 be with us? Do we know at this point in time if we're going to be able to control this disease to sort of an eliminatable level? Do you think this will turn into something kind of seasonal, similar to what influenza is like?
I'm interested to hear what Arnold thinks. I think that it's probably going to turn into something similar to influenza. It'll get less severe because we know for sure that the vaccine pulls back the severity. But it's something that we will probably be dealing with waves and outbreaks, but at a milder level as we go into the future.
Well, Emily and I have come to agree totally about this. We started out having different views early because I remember I got very much involved in SARS control, and we kept saying it was going to be with us forever. It would start to be like flu, and then it totally disappeared, which we still don't understand. But this virus is very different in the way it spreads, even before some of the new variants have come along. It is everywhere in the world. And I think I agree totally with Emily. We're going to be with this virus, and it's going to be with us for a long time. We are figuring out ways to control it. And I think that this is going to be manageable. We may never go back to exactly the way we lived before. We may start wearing masks when we're sick, not all the time, after we've achieved some degree of control. But I think we're going to be managing this like we currently manage flu, where a proportion of individuals do get severely ill. We use vaccine to control that, and we move on.
So some of the viewers were having some questions about mRNA vaccines, because as you previously mentioned, the Pfizer and Moderna vaccines are based on this mRNA technology. So Dr. Monto, could you talk a bit about how does an mRNA vaccine work? And then how do we know that it is safe, given that we haven't had mRNA vaccines for as long as we've had some other vaccine technologies?
Right. Well, ordinarily, we give the protein, usually the protein antigen that we want the body to respond to make antibodies to the virus. We develop that outside the body. Now, typically for viruses in cell culture. The mRNA vaccine works differently. It takes the genetic instruction for producing that part of the virus, the protein, and it's given into the body, into the muscle, and the antigen that we want to have a response to is produced in the body. So then the antigen is present and the body responds not only with antibody, but also with cell-mediated immunity, a different kind of response which broadens protection. We think, based on all sorts of experience, this is a very safe approach. The mRNA is destroyed very rapidly. That's why we have to be careful with freezing and the rest to preserve the vaccines. So the mRNA is gone, and thus far we've been very happy with the safety profile. We're always concerned at the start of a vaccine rollout because only a small, not only haven't we watched it for very long, but relatively small numbers of individuals have been involved. In this situation, we've had many more individuals involved in the clinical trials, but now we've rolled it out into millions of individuals. And aside from the anaphylaxis, which occurs at a very low level with all vaccines, we really haven't seen any safety signals that are more than rare. There are a couple that are being worked out, but again, they're 1 or 5 or something like that in a million.
So Dr. Monto, could you, oh wait, did you have something? Okay. Dr. Monto, could you talk a bit about what are the typical side effects that come up with the Pfizer and Moderna vaccine? So, the vaccine's going to be rolled out to more and more individuals. So what kind of side effects should people expect if they were to get vaccinated?
Well, after the first dose, there's typically just a sore arm. Most people do not have any other side effects. After the second dose with both, and that's what gives you a feeling of comfort in saying that these are related to the vaccine, just the product and not the particular company's product. There tends to be in about 20-30% of people a little bit of achiness, sometimes very low-grade fever, just for a day or two after vaccination. It's nothing that can't be managed. And it's fairly similar to what, if any of you have received the herpes zoster, the shingles vaccine, what is seen in the second dose of those who've had both typically say this one isn't as bad as the one they've had with the shingles vaccine, which is again a more traditional vaccine than this. Emily, do you have any comments?
Yeah, well, I think what I want to put a plug in for is the VSafe program, and which I'm super interested by. So one of the things that is being done with this vaccine rollout that's never been done, we just haven't had the technology to do before, is that after you get vaccinated, you get a text link to sign up for this program, and with that the CDC is running, and you get daily things to your phone to fill out what your reactions is. And so we're really monitoring the side effects to this vaccine in real time across the entire US population, which is something we've never had the technology or ability to do before. And so CDC's got amazing levels of just on the ground, symptom by symptom, what are people experiencing as they're seeing the vaccine. And so we're monitoring this in such a really robust and kind of thorough way compared to what we've done in the past, that I think it gives a lot of confidence that if anything comes up, it'll be found pretty quickly. And with all of the, the tens of millions of vaccines that have rolled out to date, the side effects have been pretty minimal overall.
So, Dr. Martin, I was wondering if you could talk a bit more about vaccine effectiveness. So a couple of questions have been kind of popping up. So one is, if somebody is vaccinated, can they still pass on the virus? Can they still be sort of a source of viral transmission to other folks?
Yeah, this is an issue where we get into what we know and what we're still learning. So the way the trials were designed, we know that the vaccine stops people from needing to go to the hospital. It prevents deaths. It prevents kind of moderate to severe disease. What the trials were measuring to see whether or not the vaccine prevents you from getting very mildly or sick, or even just carrying the virus with no symptoms that you could still transmit to the people. Those studies are still ongoing. And so that information is going to be coming out, we expect, over the next couple of months. That being said, I think a vaccine with a 95% effectiveness against preventing hospitalizations and deaths, I mean, it's a pretty good signal that it probably does reduce transmission, but the degree to which it does that, we're not sure yet. And so while this is rolling out, that's why we're still seeing a lot of recommendations to wear masks in public, be careful around vulnerable individuals, all those good kind of low cost mitigation strategies that we've had until the rollout is really taken off, until we understand more about transmission.
Another sort of a follow-up question to that, one of the viewers asked, so why are we seeing that these vaccines have different levels of efficacy? For instance, are there some mRNA vaccines which might have different levels of efficacy? And then, a follow-up to that would maybe be, do we know anything of why an mRNA might be more or less effective compared to some of the other vaccine technologies which are being used?
Yeah, so actually the two mRNA products are actually surprisingly similar. They're within the range, they're basically within the range of uncertainty with each other. And so those trials were actually, and I think it's really confidence boosting how similar the answers from those two trials were with each other. Now, as we talk about other vaccine products, we start talking about the AstraZeneca vaccine and the J&J vaccine, these other vaccines that are now being evaluated. Those are vaccines that are built in different ways. They're gonna present the antigen to the human body in slightly different way. So don't be surprised if different numbers start coming out of different products. And this is something that we've seen before. Flu vaccine, there's all these different versions of flu vaccine. They all have different levels of effectiveness. And I think that's something that we're kind of used to contending with in the public health space.
So a question for Dr. Monto. So you mentioned that under this emergency use authorization, the vaccine was reviewed after 2 months of data collection instead of the typical 6. So what do we know about sort of that discrepancy? Should we be expecting that there could be more long-term side effects that we would see after 2 months? And I guess the broader question is, how long do you need to study a vaccine to figure out what kind of long-term side effects there might be?
Well, the 2 months was chosen because most of our side effects, if there are going to be any, occur within about 6 weeks of vaccination. So they wanted to allow a median time of 2 months because the outbreak is raging and we don't want to sit and wait if the vaccine is as safe as we believe it is. And that's why that time was picked. There is always, with anything that we put in our body, either a vaccine or a drug or anything like that, the possibility for a very low frequency, long-term side effect. We don't expect to see any. Just remember the 2 mRNA vaccines, and those are the 2 only that have been approved so far in the United States, have now been used. They started getting rolled out in December, and they've been used globally. And if there were a signal after, let's say, 4 months, we would have it by now. So we're now 4+ months, and even longer than that, given the fact that some of these vaccines were actually used even before in small numbers of individuals in phase 1 and phase 2 studies. So we're pretty far out there in terms of period of observation. And these seem to be very safe vaccine. The other thing to keep in mind is that the guidance for approval said that we would be approving a vaccine if it was more than 50% effective. Why that what seemingly low bar? Well, a lot of our influenza vaccines in some years are 50 to 60% effective, and they didn't want to set the bar too high. And to our great and happy surprise, we got with the mRNA vaccines, 2 vaccines that are in excess of 90% effective. Now we're going to be looking at another vaccine, the Johnson & Johnson vaccine, which is given in 1 dose, and the publicly available data suggests that the effectiveness is going to be less. And one of the things that we're going to be wondering about is, well, is this because it's a different product, or is this because it's only given once? And these are answers which we're going to be concerned about. And the other thing about getting high effectiveness is that even if you have reduced effectiveness against the variants, coming down from more than 90% effective is going to give you a fair amount of efficacy, even against the variants, if they are reduced in the way the vaccines work.
Dr. Martin, I was wondering if you could comment on the duration of protection from these vaccines. So about how long do we think these vaccines will work in protecting an individual against COVID-19 disease?
I think it's too early to say. You know, you got to remember that people haven't had these vaccines for very long. And so I think we're still watching to see what the trajectory of their response is after they've been vaccinated. We're still also learning a lot about what the protection is after infection. You know, there are some studies that are seeing that infection can protect possibly even out to 6 months or more. And we are seeing encouraging signs in the data that a vaccine can provide a stronger protection than infection can provide. So we would expect the vaccine to be as good. And it's, you know, right now it's just sort of a prediction game to see whether the protection is still going to be good a year or more for now, or if we're going to have to treat this like we treat the influenza vaccine and provide boosts throughout time to people. And I think we're still watching that data.
I was wondering if we could switch a bit to talking about the rollout of the vaccine. So there has been some concern in minority groups, particularly Black Americans, about the COVID-19 disease or the COVID-19 vaccine. Certainly there's a history of experimentation, like the Tuskegee experiment. There is sort of people's lived experiences with medical racism. So what's being done to overcome some of the concerns that these groups have about the vaccines? And what would you tell somebody who was concerned, particularly when we're thinking about the racial dimensions of sort of the burden of disease so far with COVID-19, but also who should be getting the vaccine in the near future?
Yeah, I think that what this speaks to is the importance of making sure that vaccine is delivered by the right people in the right way for a community. That, you know, we know that people have trusted sources of information, and the more that we can get good information to trusted leaders, community leaders, the more that will help make sure that good information is getting out there and that people are able to get their questions answered and able to get their fears addressed by people that they trust. And I think that's important. And you know, to that end, I think what I really like is the more effort, all the effort that I'm seeing being put into community, kind of small community vaccination clinics, working with organizations, churches, small providers, rather than mass vaccination strategies that get people the opportunity to receive a vaccine in a trusted space from a trusted somebody that they already have a history of working with. So I think the more that we can invest in those programs, the more that we can bring these to communities that have historical distrust and concern about the system for very legitimate reasons. You know, and I think that a lot of, you know, simply kind of talking and vetting and having people have the opportunity to ask their questions and get information is really going to be important as we roll vaccines out, that it's not just a one-size-fits-all solution for opening up a big drive-through clinic that we are expecting thousands of people to come through. Those solutions are needed too, but we're also going to need these community engagement mechanisms.
Yeah, I guess one thing I want to mention for people who might not be aware, but the Moderna vaccine, one of the developers of that, one of the top developers was Dr. Kizzmekia-Corbett, who is a Black woman. I also know that a lot of the pharmaceutical companies tried to partner with historically Black colleges and universities to sort of make sure that there were, you know, a large proportion of Black individuals who were in the study population, so that, you know, we can be sure that this vaccine is acceptable and it works in a diverse group of people.
You know, there was a requirement before approval that minority groups be included. And with some of the recent vaccines, the new ones, the Johnson & Johnson vaccine, a lot of testing has been done in South Africa and Brazil, which basically have large communities of color. So the testing is fine. One of the problems we have right now is with the shortage in supply, people who are linked into the system are more likely to be able to get vaccine. We have a high demand, and that's really going to have to be looked into as we try to roll this out to communities of color.
Another question for Dr. Monto. So are there any populations of people who are not recommended to get a vaccine? For example, should pregnant women be getting a COVID-19 vaccine?
Well, the problem of vaccinating pregnant women comes up whenever we have a new vaccine, because for all sorts of medical legal reasons, the companies are not happy about moving into that population soon. If we look at the history of influenza vaccines, pregnant women were not vaccinated to any extent, even though it was an inactivated vaccine, and there didn't seem to be any reason to think that the vaccine was bad. And we knew that what we began to learn is how bad flu was when it infected pregnant women. And that's why now, from a WHO standpoint, their highest priority for a vaccine group to receive influenza vaccination is pregnant women. With the current COVID vaccines, there is not nearly as strong a signal of danger for a pregnant woman who gets COVID. It certainly is not good for her and for her baby to get COVID. And now the recommendations are, if you are in a risk group, you should just get vaccinated as you would if you were not pregnant. So the recommendations are not all that strong. They're permissive, and if in terms of a pregnant woman who is in healthcare, I would recommend that individual get vaccinated, because she is in a risk group and the risk of getting COVID in that situation is far greater than the risk of a vaccine. Emily, any comment?
Yeah, well, I think this is one of the reasons why the American College of Obstetricians and Gynecologists support vaccination of pregnant women with COVID-19 vaccine, is because of the risk to the mother and the risk to the pregnant person of becoming infected. The data shows that it can really have devastating effects for the pregnant person if infected during pregnancy. What we also know about pregnancy and vaccines from years of research on other vaccines is that the antibodies that the pregnant person makes after vaccination can then get provided to the infant during pregnancy, so that the infant is born with a little bit of an immune boost. Just the same way that, if any sort of other antibodies that the pregnant person's body has can be delivered to the baby. It works exactly the same way and may provide actually a little bit of extra protection to the infant after they're born. So it's another reason why there's a lot of focus on vaccination in pregnancy.
Dr. Martin, I was wondering if you could respond to this question. How can the mRNA technology that we're using for these vaccines, how can it adapt to new virus mutations in the future?
I love this question. So this is one of the reasons why the mRNA technology is so exciting, because I'm used to the flu world where you have to think of it entirely. You need the vaccine to include new virus strains, so you have to grow it, and then you have to put it in eggs, and it takes us all this time. With an RNA, you could just swap out the component that you need for the new strain if it needs to be updated. It's kind of like, so here's an example I've been using with people. It's like you have a Lego house and you want to change the color of the roof. With the flu vaccine, you have to start from the beginning and you have to build a whole new house. For an mRNA vaccine, you take off the roof and you put a new roof on. And it's that easy, just swapping out one piece without having to rebuild the whole vaccine. And so I think that makes us much more nimble and responsive to these variants if, for whatever reason, we find out that the effectiveness is not as good to the variant.
Dr. Monto, I was wondering if you could talk a bit about previous coronavirus vaccines, for instance, for SARS and MERS. Do we have any information about long-term outcomes of those? And then also, I believe that mRNA vaccines at least have been developed for phase 1 clinical trials for things like rabies and other viruses. Do we have any information sort of on the medium term and after a few years, what is the efficacy or what is the safety of those vaccines?
The development of vaccines is typically influenced as much by the commercial world as anything else. And there have been studies for about 15 years on mRNA vaccines, looking at those kinds of vaccines for flu and for other diseases. They really haven't been deployed because of the presence of other effective vaccines and for other considerations. As an example of that kind of a situation, there has really been no need to start using any SARS or MERS vaccines because SARS went away and MERS is limited only to certain geographic areas. So we really didn't learn anything much in terms of the technology. We are just lucky that the technology was there. The other thing about how that makes the mRNA vaccine so effective is that protection to this infection seems to be mediated. We're not absolutely sure yet. We can't call it a correlate of protection by antibodies to the spike protein. So you put in an mRNA that codes for the spike protein, and this gives you very high levels of protection. So the fact that that technology, giving one antibody to one part of the virus, gives you such high protection, is one of the few really lucky things we've had with this virus and with COVID control.
So a question I'll first direct it at Dr. Monto, but both of you can answer. Do you think we will need a yearly COVID-19 vaccine shot?
Well, we've been looking at coronavirus infections that occur on a year-to-year basis. We have a group of 4 coronaviruses that cause, in most people, just common colds. Occasionally, they will put somebody in the hospital, but that's pretty rare. We know that those viruses do reinfect. Infection gives you only relative protection. So the chances are, even with a good vaccine, even if we didn't have variants developing, we might need booster shots. And I have a feeling that we are going to need reboosting of antibodies to this virus. And it all depends on what happens in the population as well, because it all depends on how much transmission is occurring and how much immunity we have in the population. And none of this is predictable. I started saying at the outset of this pandemic, anybody who makes a prediction and says it with great confidence, don't listen to them, because it's all novel and we've all been wrong in our predictions. But I suspect we are going to need boosters. We are going to have to swap in new variants. One of the other things we didn't think was that we're going to see a whole lot of variation in these coronaviruses. They're a lot more stable than flu. What do you think about that, Emily?
I think that the speed of variation that we're seeing right now is actually pretty comparable to flu, and partly because we're seeing so much of it. We're seeing so many, infections that helps drive variation. I do think maybe just for a little while, we'll probably need some sort of booster shot strategy, but I am happy to be proven wrong as this goes forward. But when I look at it, it makes sense. Something to keep in mind though, that if we end up having to use that type of strategy, it'll be a one dose. You'll get one dose updates. You don't have to do that full 2-dose series again a year from now. You'll just continue to get one dose like we do with the flu shot.
And are we going to have reactogenicity to that one dose booster?
Yeah, you know what? I vaccinated because of my role in doing testing, and the second dose was like a piece of cake for me, no symptoms at all. So like I'm ready for another one whenever it's needed.
Okay, so I do want to mention that we are close to the end of the hour, so I just have a few more questions to wrap up with the panelists, but certainly continue putting your questions in the chat or the Q&A, and we'll try to get to as many of those as possible. I wanted to switch to talking a bit about the rollout of the vaccine, and to some people who might be a bit more vaccine hesitant. So first off, what do you think of the rollout of the vaccine so far? I think one person asked, what are the top 3 reasons why the vaccine rollout has been so slow? But I think that assumes that you think the vaccine rollout has been slow. So so why, what do you think the vaccine rollout so far? And if it has been slow, what do you think are some of the reasons for that? And I could start with Dr. Martin.
Yeah, I do think the vaccine rollout has been slow. My top 3 reasons are organization, organization, and organization. I think we don't have enough information, and our information systems aren't organized in a way to really kind of activate quickly for this job of distributing things in a kind of a top-down manner from federal to state to local. I think the more disorganization that happens, I think with distribution at the federal level, it kind of, it compounds when you get to the state level, compounds when you get to the local level. Like we have a lot to do to build up the public health infrastructure to handle this. We have to remember that we're deploying this in a public health infrastructure that's gotten very little investment over the last couple of decades. So it's a big task for a lot of kind of really archaic data systems and ways of transferring information. And what we're seeing is the impact of some of that.
The other thing is just supply. Because when you ramp up, when you're starting to produce a new product and it's in global demand, the supply is going to be limited. And besides, I agree about organization, but part of organization is proper communication. And I don't think that was handled very well in terms of issues like supply. And as soon as we can get more facilities that can produce a vaccine online, there have been some interesting developments in terms of the pharmaceutical companies that do have vaccine production ability, making arrangements with those that who do have the vaccine to use their facilities for production. That's going to be a major change if we could get greater production of the vaccine.
I was wondering if you could both comment on why do you think some in the population are so adverse to taking a COVID-19 vaccine? And we could start with Dr. Monto.
Well, I think there are some people who just don't believe that vaccines are a solution to our infection problems. And we've done many studies to make them feel more comfortable about getting vaccinations. And for some people, I don't know that we're ever going to convince them of something which is really a belief system rather than something that can be demonstrated on the basis of facts. Now, there are some who are a little concerned because this is novel. I think there we just have to show that the data are present about safety, and anything you do in life is a risk-benefit consideration, whether you think about it or not, whether you're going to go out and do something in a situation, if you're going to get on a plane or something like that. Some people are risk averse to flying, and we just have to use the data that we have to convince them, and also with information groups to show that there are many people who are really eager to get vaccinated, and to communicate from those people to those who are concerned, to try to disseminate the knowledge. Emily?
Yeah, I mean, I think it's understandable. I think some level of caution is understandable because I think everybody's worlds have been turned on their heads, over the last year. But I think that, and I also think that, we're fighting a real challenge here with the amount of misleading information that's on the internet and that is easily accessible. I think it's a different problem now than previous vaccine rollouts that we've had historically. And so it comes to making sure that we're getting good information that can be accessed from people who have questions, so that they can go to people they trust and get access to good information.
Yeah, I mean, I will also say that if you look at surveys over the past year, there's been an increase in the people who actually want to get a vaccine. And I think part of that is asking people last summer, do they want to get a vaccine? It's all very hypothetical. They don't really know what the vaccine is. But at this point in time, we have really robust safety information about the vaccine. And by the time that the vaccine is going to be available to the larger population, I think we'll have even more population. I think there will be more of a social norm about getting the vaccine. So I hope that over time, this reduction in vaccine hesitancy will sort of decrease. It's understandable why people would be concerned about this, about a vaccine, about anything that is getting done to their body. But I think at this point in time, we just have a lot of safety information, and I'm glad that we were able to talk to you two about that. We do have one quick question, which I think you could briefly answer. What is a good correlate of protection for this disease? Is it a certain level of antibodies? Or is there something with, like the viral load that you need to consider when thinking about if somebody would be protected in the future against COVID-19?
I think Arnold and I are smirking because we don't know.
But we're pretty close to know. We're closer to knowing on this than flu.
We've never figured this out for influenza. But the best way to demonstrate effectiveness of a product is to watch hospitalizations and deaths and disease go down, is to watch an actual endpoint. And that's what we're able to watch in real time now. In terms of, can you do a test to say, is your body protected or not protected? We're still a little bit a ways away from having and it probably, honestly, the real answer is probably going to be less clear, even with all of the great work that's being done in this area.
Yeah, the trickiest thing is going to be with the variants, because we've learned from flu that we can't very well predict. We know what the changes are in the virus, how well the vaccine is going to work against that change. And I think that's become clear between the UK variant, where the vaccine seems to be working better than the South African variant.
So I have a question which I think would be a great final question. Could you explain herd immunity and how these individual choices about vaccination can affect the whole community? And maybe Dr. Martin, you can start.
Yeah, so herd immunity is basically the point at which this goes away on its own, with us not having to do stuff, not having to wear a mask, not having to social distance, and all of those things. It's a scale, right? You can think about it like a balance. The more vaccine gets into the population, the less we have to do things like, social distancing, masking, all of these other mitigation measures. And so, it's to the benefit of everybody to try to get as close as we can to that quote unquote herd immunity, or trying to get as much vaccine as we can. The other thing is that's important to remember when we think about herd immunity is it protects those that may not have been vaccinated. How high can we get our vaccination rate so that we can protect those who can't get vaccinated? This is a big question right now because we're not vaccinating people that are under 16 years old. So the protection that our kids are getting is solely through the protection that we provide them as the adults around them by getting vaccinated, kind of vaccinating around these populations that can't be vaccinated themselves. And Arnold, you probably have stuff to add on top of that.
I herd immunity used to be a thing that we brought up in epidemiology classes very carefully, and because it was a kind of a theoretical concept. And I think we're overusing the term now, because herd immunity really, as you pointed out, means that the disease is going to go away in the population. And what we're after here is to have the disease go down in frequency, and then other things help to have it go away. It doesn't have to all be immunity. And what we need to do right now is just to get enough immunity in the population to get the disease to behave in a way that we can go and start behaving in our normal way. And whether it goes away completely, which I doubt because of immunity, or not, is really irrelevant, as long as we can control it and don't have hospitals filling up with cases that can't be handled.
Well, thank you for those responses. And I would like to thank all of the viewers for taking time out of your day to learn more about COVID-19 vaccines. I would like to thank our panelists, Dr. Monto and Dr. Martin, who have been, very busy doing the research, but who have also spent a lot of time doing these public outreach events. And I think that's very important. And also a big shout out to our chat moderators, Dr. Ryan Malash, Dr. Nina Masters, and Peter DeYoung, who were busy answering all of your questions. So again, thank you for attending this session of the Vaccines and COVID-19 Teach Out. I hope you have a wonderful day.